COVID-19 cases around the country are increasing daily. While hospitals and healthcare workers are trying their best to treat those positive cases, they're also exploring telehealth and virtual care to prevent overcrowding hospitals and containing the spread of coronavirus. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hederle, senior writer with AHA. Today, Dr. Gregory Esper, who is Associate Chief Medical Officer and Vice President of Lean Promotion at Emory Healthcare, as well as Professor and Vice Chair of Clinical Affairs of Emory Neurology, will discuss how Emory is using telemedicine to combat the COVID-19 pandemic.
Thank you, Dr. Esper, for being with us today. Can you talk a little bit about how Emory is using telemedicine to respond to your current COVID-19 cases and beyond? Are there any specific examples or practices you can share with us?
Telemedicine offers solutions for both the patients that are displaced and as a model for sparing personal protective equipment. And as such, we've at Emory have rapidly implemented an outpatient telemedicine platform. Most organizations that have an infrastructure that's already been developed through vendor relationships were able to, possibly flip on a dime. For those of us that did not have hardwired infrastructures in place, we needed to take different steps to do that. And liberalizing the use of various resources such as Zoom, FaceTime, Duo, and other solutions, Skype for business. Organizations are able to leverage audio-video telemedicine to serve their patients on the outpatient side. But in order to do that, we had to take a very structured approach at Emory Healthcare, which included things like policy development. How are we going to allow people to use telemedicine? How are we going to train them? How are we going to get them familiar with the rules around telemedicine? How are we going to certify them on a platform that we want to deploy? Once we certify them on the platform, how do we ensure that as we develop best practices, they can be deployed to those who want to use those techniques and that infrastructure to deploy care to their patients. And so that's some of what we've developed on the outpatient side, and we can potentially talk more about that if you're interested.
Yeah, thank you so much for that. And what about your inpatient side or emergency department side? Have you instilled any practices in that capacity?
And we have, and so specifically for acute care telemedicine, we already had our tele-ICU in place. Dr. Timothy Buckman has been a champion for that, both at Emory and throughout the world. And EICU was already in place. We have dabbled in some pilots for inpatient telemedicine. Specifically, our nephrology team has already been doing telenephrology consults, not within Emory Healthcare's walls, but in other institutions in rural Georgia that don't have access to nephrologists. But COVID-19 has made it necessary for us to deploy telemedicine both on the inpatient side for specialty consultation and for hospital medicine, as well as in the emergency department. Specifically for the emergency department, what seems to be the burgeoning use case is to take the influenza-like illness patients that are of lower risk, that don't need to be urgently seen in the emergency department for nebulizer treatments or for severe respiratory distress, and to take those less severe patients, what we would call mild patients or ESI 4 and 5 patients, and divert them into a stream where they are put in a waiting room and then go to a nurse presenter room where a nurse presenter who is already donned in personal protective equipment can actually present that patient to an emergency medicine physician who is in a control room. The first reason is that the nurse presenter actually can remain in personal protective equipment precautions, including droplet precautions, contact precautions with gown and gloves, and eye protection, and they only need to change potentially if their garment gets soiled, or they would change their gloves. They potentially can keep on their gown and they can keep on their goggles, as opposed to changing, going in and out of rooms of different patients. And additionally, whereas an attending physician would have needed to go into the patient's room to assess them, donning and doffing personal protective equipment for each patient, now because the attending is in a control room, assessing the patient via video and an electronic stethoscope and a pen light to look in their mouth, we can actually perform a screening examination that is equivalent to the exam that would be performed in person. And the initial stages of our pilot, we actually had the emergency room physician perform the visit via telemedicine methodology, and then actually go and see the patient in person to, in fact, make sure that the deployment of the use case was, in fact, equivalent. And indeed it was. And so we've begun to take this use case and implement it further in our emergency rooms across our system. I did want to mention another use case that we are developing on the inpatient side. As you can imagine, with visitor restrictions and with patients so close to end of life, especially if they are COVID-19 positive and having significant difficulty, it's very difficult for not only the patients but also families to be with their loved one towards the end of life and to participate in end of life decision making. We have deployed with our palliative care group, Drs. Tammy Quest and Dr. Joanne Kuntz and Dr. Dio Cabliaratos, a mechanism to deliver palliative care consultations in the ICU for patients that are towards end of life. And what that looks like is that the palliative care physician may be either in the room or outside the room, but the patient's family is attending via telemedicine, and the patient can see their family member, or if their family member and if their family member is awake and can participate, they can interact with the family that is on the telemedicine software and participate with the clinician in end-of-life decision-making. We've deployed about 4 or 5 palliative care consults to date, and we are rapidly trying to scale this across all of our hospitals. And it has been a tremendous boon for patients that are at end of life and the families that are also dealing with those end of life considerations. So it's important to share this with our community because some of our most vulnerable patients can benefit from telemedicine practices in the ICUs and at end of life.
Yeah, that's definitely important to make sure that you have the best practices in place for spread and scale. You've had to make these changes very quickly in the last couple of weeks, which involved training providers, adjusting their workflows, etc. What have you learned in making these rapid, quick changes? And are there any outcomes that you can share from the changes that you've had to make?
Well, I can tell you that the first and biggest thing that we needed to do in order to get everybody comfortable with this was to deploy a training module for the clinicians, the physicians, the advanced practice providers, and even some nurses and administrators that took our training module. We've been able to train over 1,600 people within a span of 2 weeks on the basics of telemedicine, how Georgia defines telehealth and telemedicine, the laws that govern the use of telemedicine in Georgia and federally, and what we call telebedside manner, how to actually conduct a telemedicine visit for the patient and for the family, and the best way to do it for the provider. We were able to take folks through that certification module and then allow them to be able to deploy telemedicine in their practice. Another aspect of what we've been able to do is to make sure that the certification lives under their privileging and credentialing. And so that's a very important aspect of developing care as well, because we have to be able to perform the services that we do as clinicians under the standards by which everything else is governed in our health system. And so we worked on that policy with our legal team and our chief medical officers at all of our sites. And it's under that policy that we have delivered this certification module. Additionally, because we're a teaching and academic institution, we have had to engage in discussions with our graduate medical office to decide how learners, residents and fellows, and even medical students can potentially participate in telemedicine. So we've made the modules available to learners, and we are working with not only the GME office, the Graduate Medical Education Office, but also program directors and attending physicians who supervise trainees to understand what needs to be in place for these trainees to not only learn, but also deploy telemedicine care to their patients in their environments. So that has also been something that we've worked through and worked on. And of course, the most important thing and the big lesson learned for us is to employ a hub and spoke model. You can imagine that with a small telehealth team, which is about 6 people for a health system that encompasses more than 24,000 workers, we actually have to figure out how to be most efficient in the use of our resources. How do we actually get the central telehealth team to create the environment for our clinicians and our sections and our divisions to be successful, while not being overwhelmed and overloaded by all of the questions that can come from the people that are deploying telemedicine? That's why we created the hub and spoke model. The hub and spoke model allows us to be the hub, and each section or division that is deploying telemedicine has a dyad partnership with a clinician, at least one clinician and at least one administrator who are responsible for taking the best practices from the hub and deploying it in their section or division, and then also being a resource for their section and division to answer questions, to help get them up on the platforms, to help with training and the train-the-trainer model, so they can actually be able to deploy a telemedicine in their areas. And that actually has been an excellent development for us. We actually use that hub and spoke model and those dyad partners to talk with every night for the past couple of weeks as we deploy telemedicine. We call them telemedicine office hours, where we can be available as the hub to the spoke dyad partners to be able to answer questions about training, about technology, about billing and coding, and about the situational awareness that each of these divisions and sections face daily as they're trying to change their care models in the deployment of telemedicine on the inpatient and the outpatient side.
Dr. Esper, in response to COVID-19 cases currently happening in your community or at your hospital, do you have any recommendations for other hospitals trying to use telemedicine to combat COVID-19?
but clearly, I would the major advice is to make sure that you are following all federal and state laws, not only legally but also with compliance. The billing rules have changed somewhat. Organizations and practitioners of telemedicine must be familiar with the appropriate ways to not only deploy telehealth, for instance, in the prescription of narcotic medications across state lines, but also how to make sure that they are appropriately billing and coding the visits so that payers will be able to know that the visit is a telemedicine visit and be able to pay it appropriately. When they receive the bill. Additionally, it's critical for anyone deploying telemedicine to be able to educate the patient about what the best practices in telemedicine are and also what can't be done via telemedicine. For instance, it would be hard to assess a patient that needs a hands-on abdominal examination that's by telemedicine. Telemedicine examination standards are available and should be employed judiciously. And it's critical to be able to make sure that patients understand the benefits of performing telemedicine examination and engaging in a telemedicine visit, and when that visit actually needs to turn into an in-person visit. And that documentation has to be ever present in the medical record because risk doesn't go away. And our desire to help patients, must be deployed with the appropriate judiciousness with this new tool that we have in doing so for many of us who have not been doing telemedicine to any great degree before. So those are the major recommendations to make sure that from a compliance and legal perspective, you are doing the right things, to make sure from a clinical perspective, you're assessing the correct things on telemedicine and turning those visits into in-person visits if and when necessary, especially during COVID-19 if they are time sensitive or urgent.
Thank you, Dr. Esper, for sharing your insights. We know the use of telemedicine is going to expand as hospitals continue to treat cases and contribute to flattening the national curve. So we thank you again for sharing your tips and resources with the American Hospital Association.
It's my pleasure. Thank you for having me.